Thank you very much for the nice introduction. Thank you for the MedCup organizers to invite me. So I'm effectively a nephrologist and implicated in the domain of organ transplantation since 30 years. And I had the intention to give you an idea about the extraordinary progress which has happened during the last 70 years in this domain, and which has changed the lives of thousands of persons. So in 25 minutes you cannot explain everything about organ transplantation, so I will mainly talk about what I know, that's kidney transplantation, and in my talk I will give you the role of transplantation as a revolution in the treatment of terminal failure of vital organs, a small overview of the history of organ transplantation, the mechanisms of rejection and the need for lifelong immunosuppression. To transplant organs, you need organs, so I'll talk about organ donation and organ allocation, and finally part about living donor kidney transplantation. So the fate of patients with end-stage failure of vital organs until the mid of the last century was dire. There was no therapy, and these persons mostly died. So in in the history of medicine, doctors thought a lot about eventually taking healthy organs from donors to replace these, but there were incredible obstacles. First, you had to procure the organs. Organs are rapidly damaged due to ischemia, lack of perfusion, and then there's the problem of rejection, which has not been understood for a very long time. It's only during the second half of the 20th century that the mechanisms of rejection of allogeneic organs were understood. And then very rapidly, organ transplantation has become the major therapy to replace failing organs and had an incredible impact on medicine. So to point out the tentatives, there's the history of Saint Cosmas and Damian, which is depicted on, which are saints, so with divine help that this happened, and apparently they healed a Roman soldier by transplanting the leg of an Ethiopian enemy. We can only hope that this was not a living donation, but this is anecdotal evidence. Really, the history of transplantation started at the end of the 19th century. Alexis Carrel, who was a physician who was interested in skin transplantation for soldiers, among others, during the Second World War with terrible skin wounds, really initiated the field of experimental transplantation with animal models. He introduced the concept of vascular anastomosis, and then finally he succeeded in transplanting, but all these organs were rapidly rejected. So he was also one of the first to describe the phenomenon of rejection, but he didn't understand the underlying mechanisms. He was finally convinced that transplantation would never be possible. The first real transplantation, in fact, happened also once the genetic basis of rejection was understood. Professor Joseph Murray, who was also a plastic surgeon, also had worked in skin transplants, and he postulated that when you have a patient with an identical twin who is not genetically different, he would not reject the organ. And so he transplanted Richard Herrick in December 1945 with the kidney of his brother Ronald, an identical twin, and effectively no rejection occurred, confirming the basis of a genetic underlying difference which is responsible for rejection. So the donor lived long until 2010. The recipient, and which is also already illustrating a problem we have, he had an autoimmune kidney disease. He received the organ of an HLA identical brother, so he had recurrence of his kidney disease and died about 10 years later. This was revolutionary, and he also received a Nobel Prize in 1990. And it's also interesting in the writings of Joseph Murray is that already at this first living donor kidney transplantation, he was confronted with the ethics of living donation, because taking a normal person and doing a major operation not for his own benefit but for another person's can raise ethical questions. The technique he developed is still the same. In fact, here you have a standard concept of a kidney transplantation. The diseased kidneys are depicted here, and then the kidney is in fact placed in the lower le bassin, and with anastomosis on the iliac vein and artery, and implantation of the urethra in the bladder. This is done because the vascularization of the urethra only depends on the renal artery in a short first segment, and if you leave your urethra too long, it's developing necrosis because of ischemia. So the kidney has to be placed next to the bladder. Developed initially in the 50s and is still the current technique. So how is rejection happening? And the underlying, as medical students, you know that the underlying activation of immune cells by an antigen occurs in the interaction between a professional antigen presenting cell and a T cell, which is mostly CD4 helper T cells, where the T cell receptor interacts with the major histocompatibility complex class 2 for CD4 cells, class 1 for CD1 cells. And we are, in fact, tolerant against our own MHC peptide complexes, but and this is the particularity is that there is an extraordinary diversity in HLA proteins, and the main reason in evolutionary terms is that this provides a species to have already some individuals who defend themselves in an optimal way against new viruses or bacteria. And so this diversity with thousands of different HLA alleles in a combination of a lot of low-key, class 1, class 2, makes it that there are nearly no individual are completely identical in terms of HLA. And so during the initial transplantation, you have the antigen-presenting cells of the donor, which are called passenger leukocytes, which are transferred with the graft and which activate a large proportion of the naive T cells of the recipients and cause rejection, which explains the high incidence of rejection early after transplantation. To activate the T cell, you not only need the signal 1, which is the interaction of the T cell receptor with the MHC, but also co-stimulation with a variety of co-stimulatory molecules. Afterwards, the CD4 helper T cells provide help mostly in the form of different cytokines to cytotoxic T cells, which are CD8 or B lymphocytes. Unfortunately, the story stops not with the disappearance of the donor-derived passenger leukocytes, which would be a nice thing, because afterwards there would be no more efficient T cell activation. But later on, in fact, these donor HLA molecules, which are shattered continuously, are picked up by the recipient's own antigen-presenting cells, and this is called the indirect recognition. And so HLA peptides, which are allogenic, are presented in the context of self-MHC and activate T cells. And on the other side, B cells present the same peptides, and these T cells activated by the indirect pathway trigger the production of huge amounts of anti-HLA antibodies, which can cause then antibody-mediated rejection and chronic rejection. So the HLA, these major histocompatibility antigens, play a big role. This is a publication of the Eurotransplant registry database, which large numbers of transplants, and they have stratified them in 0 class 1 mismatch and then 1, 2, 3, 4, because we have 2 HLA-A and HLA-B alleles, and then with a 0, 1, and 2 HLA-DR class 2 mismatches. And you see every time, every mismatch increases the loss of the risk to lose your graft from rejection. So there are fundamentally 2 ways to avoid this. Is first, avoiding the mismatches. Second, adequate immunosuppression to prevent rejection. So this acute rejection, they are fundamentally, I don't get into the details, but the early rejection episodes, which are triggered by the passenger leukocytes in the direct pathway, are often cellular, with inflammation in the tubular cells and the interstitium, and then afterwards you can also have a T-cell mediated cellular rejection at the level of the blood vessels, which is another grade, which is more severe. And then you have these anti-HLA antibodies, which are produced by B cells and which fix mainly on the vascular endothelium. They trigger then also a form of vascular rejection with arteritis, glomerulitis, and peritubular capillaritis, which is a deposition in the peritubular capillaries. And there you can identify complement activation by these antibodies, which is a specific sign that it's an antibody-mediated rejection. These rejections, have an impact on graft survival. Here you have no rejection, cellular rejection, vascular rejection, antibody-mediated rejection, and you see that this has a major impact on the proportion of grafts that are lost over time. And the severity of rejection episodes is also important, because when you have an acute cellular rejection that you treat with steroids or other therapies, and these kidneys completely recover their kidney function, the prognosis is excellent. But when you lose function, so you have an irreversible damage of your kidney, it has directly an impact on your graft survival. So immunosuppression had a major impact. In the 50s, there was hardly any immunosuppression available. The first kidney grafts, allogeneic, were treated with corticosteroids and azathioprine. And then over time, there were a large number of new drugs which were accepted by the regulatory authorities, so here the European medical agencies. Cyclosporin, a calcineurin inhibitor, had a major impact. This really made transplantation of other organs such as hearts, lungs, and livers possible. Afterwards, development at the end of the 90s of mycophenolate mofetil, and 1998 basiliximab anti-IL-2 receptor antagonist. This is still our current gold standard regimen, anti-IL-2 receptor induction, tacrolimus, MMF, and steroids. And this has not changed for 20 years. And this is another a real problem in transplantation, that there has been relatively few progress over the last 20 years. There are new drugs, but they're often quite expensive, and among others, belatacept is not reimbursed in Belgium and has never become available here. So here you have a slide which I often show, which is from the transplantation cohort at the Erasmus Hospital here in Brussels. Over time, they've maintained a nice database since the first kidney transplantation in 1965. And you have here 5-year time periods, and you see that over time there has been a massive improvement in graft survival, free of rejection over time. You see the first grafts here, after 12 months, already 40% were lost, mostly due to rejection. Now graft loss by rejection is really an exceptional occurrence. And most patients, especially older patients that are transplanted, they die with a functioning graft. So this had a major impact. End-stage renal disease. Nephrologists are fortunate because we have a replacement therapy, which is dialysis, so these people don't die any longer. But dialysis therapy, even well conducted, corresponds to about 10% of a normal renal function. So it's still associated with a major increase in mortality, mainly cardiovascular mortality. And here you have the expected life years, the remaining life years. So here for a 20 to 24-year-old patient in dialysis, you can add 15 to 18 years on average. And so they die very young. And here, as compared to a normal general population. This slide shows, in fact, the ERA Hereditaire registry and the USRDS registry, and so the numbers are very similar. Kidney transplantation, even if it does not restore completely to the life expectancy of the normal general population of the same age, has a major benefit in terms of survival expectancy, particularly in younger patients. In older patients, it's still a benefit in terms of relative improvement. In absolute terms, it's less important. But these patients benefit from a better quality of life. So, based on these results, transplantation has become really a standard of care, among others, for patients with end-stage renal disease, but also other diseases like heart failure, lung failure, liver failure, and to avoid mismatches, you need a big donor pool. Your chance to find a matching donor increases, and so Belgium collaborates in the context of Eurotransplant, which is an association of the Benelux, Germany, Austria, and Hungary, Slovenia, and Croatia. And here you have the patients on the active waiting list, and you see that in Belgium in 2019, I've chosen because 2020 was a little bit different because of the COVID epidemic, about 900 patients on the waiting list. You see here Germany, 7,100. But then you see the number of organs transplanted. Kidney, Belgium, 424 kidney transplant deceased donors in 2019 as compared to 1,532 in Germany, which has 8 times more inhabitants. So Belgium is really at the top of transplantation worldwide, mainly because of a very high donation rate. You can compare with Austria here, which is approximately the same number of inhabitants in Belgium, and you see that the numbers of transplant in Belgium are higher as compared to the Netherlands, which has 2 times more inhabitants than Belgium. Belgium transplants far more livers and lungs than the Netherlands because of more deceased donors. And here to compare these countries, normally the transplantation donation rates are expressed per million inhabitants per year, because then you normalize for the size of the population. Now we'll talk about the type of donors: opting out donation, opting in. So here presumed consent. You see that the donation rates on per million inhabitants per year in Belgium are quite higher and are comparable in Austria and Belgium, much lower in Germany, which has an opting-in system. In the Netherlands, they have lower donation rates, but they have a lot of living donors. More than half of the transplantations are living donors, which a very high overall number of transplants. So deceased donation, the Belgian law since 1986 was one of the first countries in Europe had a law of a presumed consent. So if you don't formulate an opposition, you are presumed to consent. This consent or opposition can be expressed in different ways. It can be towards your family or next ones. It does not have to be in written form. So the transplant professionals, in case of a potential donor, they ask the family, does the deceased one has expressed opposition against donation in place of asking, do you agree that we take the kidney of your son? Then many people are afraid and say no, but if you shift the responsibility for the donation on the deceased person, the consent rate is higher. Now, since I think, July 2020, this has been formalized, and this is very easy now to do via the public site massanté.be of mijngezondheid.be. You log in with your It's Me account. you can go there and really say if you are consent or opposed to a donation of organs or other corporal materials and so forth. So this is now become very easy to express consent or opposition to donation. I will finish with living donation, which is a very important topic. Sorry. Because as we already said, it's a surgical intervention where you remove an organ in a perfectly healthy person, normally contrary to medical ethics. But there's an important indirect benefit for the donor, which is the restoration of health in a loved one or child, and then also to realize common projects, permit a partner to work, have children, etc. So it's something which can be very beneficial for the donor too, and the long-term results with living donor kidneys are much better than with deceased donor kidneys. So many transplant professionals promote living donation, but you have to safeguard the donor at any cost. So this implies a correct information of the donor. He has to provide written informed consent, and there's also quite extensive medical evaluation to be certain that the donor does not have a health condition which predisposes him to complications. So the short-term risks are mainly surgical, minor complications about 10 to 15%, serious complication which imply prolongation of hospitalization or need for re-intervention is 2 to 3%. Mortality associated with living donation is very low. It's really 3 per 10,000 or 0.03%, but donors have to be informed that it's not impossible. Then there's the risk of a slight reduction in the glomerular filtration rate, which can at the long term increase the cardiovascular risk, the risk of hypertension in women, eventually of pregnancy-related complications, and eventually slightly increased risk of end-stage renal disease. So the donor workup is mainly to exclude patients which have a substantially increased risk for short and long-term complications. And so the data are difficult to interpret. The first publications in the Lancet, which was in the 80s, said kidney donors live longer. And so in fact, they had a better survival long-term for donors than for the normal population. But this is because donors are a highly selected population. Only the most healthy ones are accepted. And so it's normal that they have better outcomes. But now there have been data here from Norway, which have a very good registry of all patients, and which have shown that effectively there's a slight increase in the risk of all-cause mortality in kidney donors, which is discrete, but which is existent. And also there is a slightly increased risk for the development of end-stage renal disease. And so we use tools like estimation tools for the risk to develop end-stage renal disease during a lifetime, where you enter a sort of standard categories. It gives you the risk of a lifetime risk of end-stage renal disease. And here for a young woman with good kidney function, normal blood pressure, this lifetime risk would be 0.3%. If you multiply it per 5, you're still at 1.5%, which would be acceptable. But a young man of 20 years with high blood pressure and slightly reduced kidney function, he would have a lifetime risk of 4.5% without donation. So if you multiply that per 5, this would be an unacceptable donor. So safeguarding the donors, I'm over my time, but there are a lot of formal rules on management of the donor, also a mandatory yearly follow-up of the donor, which is really strict. And unfortunately, this is not happening in many countries, and I really want to insist here to close that we have to protect fragile people to become victims to donation. These are persons who really sell their kidneys because they're in desperate situations and they will never be followed correctly, and this is completely unacceptable and criminal. Other practices which I find personally unacceptable in the US, where waiting times are long, they're setting up websites for altruistic donation, and then you have altruistic donors from Africa who give their kidney to American recipients. So you can tell me that it's forbidden to have any financial compensation. I cannot believe that you have altruistic African donors for American patients. So this would be completely unacceptable in Belgium. And I thank you for your attention. Thank you.